go
Yes.
ahead.
So we had some excellent talks today by Dr. Lalit, Dr. Pramod Bende, and even Anand. And Dr. Vishali made some excellent points about uveitis. Actually, it was brought out by a very good question. I just want to add one comment on that when it was asked whether Mantu or gene expert is more sensitive. And Dr. Vishali gave the absolute right answer that it's not just one particular test, it's about the clinical diagnosis, the clinical acumen. As of today, whether it's residency or fellowship, a lot of us, even in established practice, assume and think that one test can fit everything and give us a diagnosis. But the extremely important point which Dr. Vishali made was that a test positive is not disease positive, and a negative test does not rule out disease. As was shown in our first case, Toxo was misdiagnosed just because MAN2 or something was positive. The patient lost her eye. But again, now I would be talking about. Um, okay, that's okay. So I'm not going to change too much on my video and uh, background at this time, but usually these topics are one-day conferences or two-day CM conferences, which I've tried to cover in about 10 minutes. So diabetes, the number of diabetics in the world exceeds 400 million, and more than 70 million in India have diabetes, which is about 7 crore. The number of trained retina specialists is just over 1,000. So we have about one retina specialist to close to about 70,000 diabetics, not just the population. 70,000 diabetics, and you have one retina specialist. What's the need of the hour? We need to have more and more people, including general ophthalmologists, taking care of the diabetic population as well as diabetic retinopathy. So, the classification, earlier there was an Adley House classification, then we had ETDRS classification. They were more for research and different grades, but it was not easy to remember. But the International Clinical Diabetic Retinopathy Disease Severity Scale gave some modifications, and it was much easier to remember them. And if you have a patient with any microaneurysm, that patient qualifies for mild diabetic retinopathy. What about moderate? If a patient has anything more than microaneurysm but less than severe. So in the severe category, you have the 4-to-1 rule, 4 quadrants, 20 hemorrhages, or 2 quadrant venous bleeding. When anyone between microaneurysms and the severe variety, that means they may have hard exudates or cottonwool spots, would fit into moderate NPDR. And as I said, in severe category, you have hemorrhages in all 4 quadrants, more than 20, or definite venous bleeding, or prominent IRMA. And the good thing is that there's no very severe diabetic retinopathy compared to the earlier classifications. It's just mild, moderate, severe, and the proliferative diabetic retinopathy, which has any neovascularization or vitreous hemorrhage. So I will just go back here that any moderate diabetic retinopathy is something which should trigger an alarm for a referral for a general ophthalmologist who is not able to take care of the more advanced forms, including injections or lasers or vitrectomy. So the treatment of diabetic retinopathy includes good systemic control, which means it's not just diabetes. It includes systemic control means blood pressure, lipid profile, renal profile, anemia, as well as sleep apnea, which has been shown to be a major factor in diabetic retinopathy. And regular dilated eye exams, these can be found in various guidelines. The mainstay of proliferative diabetic retinopathy in the early stages is laser photocoagulation. I'll also talk about the role of injections in PDR. Obviously, the role of injections is the standard of care in diabetic macular edema, and vitreous surgery is recommended in advanced PDR. So the first thing I will be talking a little bit, I'll be emphasizing a little bit of systemic control because it's very important for everyone, including general ophthalmologists, to prevent progression of diabetic retinopathy from the earlier stages. So the UK PDS was one of the first studies which showed us that the systemic control, especially with HbA1c, being less than or equal to 7% reduced the microvascular complication rate. In fact, by 35% for each HbA1c point. And then we had the Accord study published in 2010. It was over 5 years that we had these results. But what is important from this slide is that they had an intensive control of 6% HbA1c versus 7% or more. What it showed that although 6% patients did slightly better, they had more hypoglycemic events. So it's at this point of time, the recommendation is not to aim for 6% HbA1c. If we have a diabetic patient, don't go for a non-diabetic kind of control. It's okay if a patient has 6.5 or 7%. But importantly, you must also look at the lipid profile. A lipid profile meaning normally when you do a lipid profile, you will have a range given by the lab that this is above normal, this is average. But in a diabetic patient, even a normal level, which is normal for a normal person, is high. So for a diabetic patient, you need to get it even lower, and even otherwise, even if it's in the normal range, it may be better to start them on statins and also reduce their triglyceride level. Again, one more thing which was brought out was blood pressure of 120 was not required to be brought down so low. But any blood pressure level between 120 to 140 was acceptable as systolic. Another important point in diabetic retinopathy is that there is a delayed effect. You may have patients whom you tell, hey, you have to control your sugar, sir. You have diabetic macular edema. I have been giving injections. The patient may ask, my vision is not improving. Why are you giving injections again and again? And you say that, okay, sugar has to be under good control. And he may say that, okay, my sugar is under control for the last 3 months, ever since I have come to you. But the important point is controlling the sugar now doesn't remove the diabetic retinopathy now. It takes time. It takes time for about 2 to 3 years for, if you see this graph on all of these, sorry, I go back. If you see this graph, all of these take time between intensive and conventional control for the gap to start appearing at about 3 to 5 years. But the good thing is diabetic control has long-term memory. So if the patient starts doing good control, in the short term, you may not find too much of a difference, but in the long term, they do very well. I'll briefly touch upon DME management with just one DRCR protocol study because it covers 3 standard injections which we have available in our practice now. Protocol T, which compared Avastin, Lucentis, and Eylea, just to use the terms which are familiar with our practitioners. What it showed is that overall the gain in vision was about 2 to 2.5 lines, slightly more for aflibercept or Eylea. But then if you look at a subgroup of patients who had a baseline vision of less than 612, those were the patients who responded very well among all 3 categories of anti-VEGF, but aflibercept had a clear-cut more beneficial effect than the other 2, although at over 2 years, ranibizumab also showed very good results comparable to aflibercept. But if you have a patient who has a baseline vision of better than 6/12, you do have patients who have good vision at baseline. There, the improvement is about 1 to 1.5 lines, and all 3 of them were quite similar in terms of their efficacy. What you need to look at is the safety profile whenever you choose the drug. The biggest problem, 15 injections in 2 years, kind of impossible to give in even an insurance kind of setup where you have someone, the third party is providing for the payment. It's impossible for patients to come every month and get an injection. What's the alternative? Dexamethasone implant is an alternative, but it does not have as good effect as the anti-VEGF drugs. As you can see here on the right side, the dexamethasone implant in pseudophakic patients had about 6 to 7 letters of improvement. We were talking about anywhere from 10 to 18 letters with anti-VEGF, but with dexamethasone in pseudophakic patients, it was about 6 to 7 letters, which means in phakic patients, as you can see the other graph, they had less vision gain because of progressive cataract after Ozurdex injection. But then it can be used as a more sustained add-on over anti-VEGF injections. I'll also show some cases of DME and PDR. This was a patient who had stable DR, non-proliferative, and had cataract, because of which his vision had dropped to 20/50, and we advised phacoemulsification, which was done. We all know on the first day they all do very well. 20/26 six vision, patient is happy, but all the problems start after a month or so when these patients start developing macular edema. So this is a very important point to note for all ophthalmologists, that if you operate on a patient with diabetic retinopathy, no edema at baseline, patient is good, just has cataract, and you do a cataract surgery, they can be at risk of developing macular edema later on. So I'm not going into the details. I'm not able to cover in such a short time what should be the protocol, how should you give injections at the baseline with the cataract and all. That's probably a different talk altogether. Anti-VEGF in PDR. You must have heard a lot of patients with proliferative diabetic retinopathy getting injections. I'll show you by example what happened in some of our patients. This patient had bilateral PDR and had 6/6 vision in the right eye. I'm just going to show the right eye what happened in this patient. This patient, you can see the nice neovascularization of the disc, and I mean, you might wonder, I should not probably do a PRP. Won't look good in such a nice eye. But we gave injection in this patient, Avastin, and then after 1 month, you see the neovascularization is completely disappeared. But the usual thing which happens, patients with diabetic retinopathy do not come for follow-up regularly. This patient was lost to follow-up for 8 months. And then what happened? The neovascularization came back along with vitreous hemorrhage. And there are numerous publications on this, that long-term prognosis of just anti-VEGF in PDR is not very good. They do come back. And what about these kind of patients with extreme tractional retinal detachment? I'll just briefly show that surgery is an option in these cases, but it's not easy. Extremely difficult surgeries with segmentation that you have to do. You may have to do bimanual surgeries. But yes, it's possible to get some outcome in these patients from just light perception. You see lower down the same eye had by 1 week got 2400, and by 1 month he had got 2200 vision. And the last point is about when to refer. All ophthalmologists are expected to examine fundus and diagnose diabetic retinopathy. As of today, many residency programs are extensively training in the diagnosed management of medical retina. So hopefully the gap between one retina specialist and 70,000 diabetic patients will reduce in the near future. But if you are unsure at this point of time, refer any case of moderate diabetic retinopathy, even if the vision is good, or any patient of diabetic retinopathy if the vision is less than 6/6, you please refer to a retina specialist. Thank you very much for your kind attention.